Recording in.
Okay, we are ready. Hey guys, how is everybody tonight? Are we excited for day 3? And you get to see me tonight for a little bit. I'm going to do the game for a little bit before Jen comes on. And I've got us on recording. We've got about 1 minute, but I wanted to make sure that everything was on live and I can see us on live on Facebook so I can see all the questions. And yes, we are on live. So come on Zoom, and because we're going to play a game, so you can type in the chat what the answers are to the game. So that will be fun. And I've got Zoom going up and I've got Facebook on. So we should be good to go in just about a minute. So get your typing fingers going. I am not a fast typer, but there's a bunch of y'all that are fast typers for sure. So we're going to play a game tonight. And I'm going to go ahead and get my screen going so we're all here at the same time. And this is an EKG millionaire game. So see if you can hear me. Type in the chat if you can hear me okay. I just want to make sure. Where is my chat? Somebody type in the chat for me, because when you type in the chat, it pops up on my screen. Always takes me a second to find it. There it is. Thank you. I appreciate it. For some reason, whenever I share screen, the chat goes away. Thank you, KJ. You are so fast. Yes. Okay. So just making sure that everybody can hear me okay and you can see my screen. So I've got Baby Yoda going up here and we are right on the button at 5:30 PST. So jump on and let's get started with who wants to be an EKG millionaire. I don't know if you remember this game for quite a while back, but I love to play this game, and I always pop in the gentleman that built the game, and so that I give him credit for that. So I like to bring that up and let that stay up for just a second so you see it, because he lets people use his games for free as long as they're for education. So I always like to do that first. So here we go, typing in the chat. The sinus node, I started off kind of easy, so y'all can do some easy ones first. The sinus node creates a what for 100 points? The sinus node creates a what that is usually upright and comes in, it's usually upright and it's coming from the atrium. So type in the chat. Okay, I've got some already. KJ and Marcia are already typing in. Yes, it is the P wave. Let me get my arrows going here. Yes, it is the P wave. So if y'all have watched this game in the past, only the first 2 or 3 questions are the same. So after that, they are all some new questions. I went with what was Jennifer doing this last week. Yes, Anna and Chaz. So I've got a bunch of people got that right. So next question for 200 points. See if you can remember this. And Jennifer talked about this last night, and I think she mentioned it the first night too. What node functions to create a normal delay? So I always like to say this is the node that says, okay, I'm going to take that information that you're giving me from the sinus node, and I'm going to say, wait, stop, I need to look at the ventricles. And then yes, this is the AV node. Y'all already have it. You're already typing it in. Perfect. I've got a bunch of people. Marcia, KJ, Anna, Christina is on, and Chaz Seal. I think I'm saying that correctly. Yeah, so the AV node is the one that makes sure that the ventricle is ready for that impulse. And that can be the area where there's some WPW issues too. So that's something that you have to kind of watch out for. So now, let's talk about a little bit of the numbers for 300 points. The numbers, the QRS width should be less than. I have to remember it in blocks, but the physical number needs to be less than what? Needs to be less than what? I've got less than 90. I've got less than 100. I've got less than 20 milliseconds. And I've got less than 120. So what do you think? I've got Marcia. Am I saying that right? I hope I'm saying that right. Hey, Paul, you're on. Yay. Yes, it is 120 milliseconds. I like to remember it as 3 blocks, get it smaller than 3 blocks. Some of the research will even say you have a little bit of an interventricular delay if it's at 110 milliseconds. So somewhere around there, 110, 120, less than 3 blocks, less than 3 blocks. So, and why do you think it needs to be less than 3 blocks? I'm going to give you a second to type that in. What do you think? It's got to be less than 3 blocks because if it's too wide, we've got some stuff that's going on in the ventricles. The ventricles themselves are like, oh my gosh, this is crazy. I'm getting like all these blocks that are coming in there. So we want to get it less than 120 milliseconds. Okay, so here's another one. So these are just some numbers. I put these in as the easy ones at the very beginning. What is your normal PR interval? And Skelly and Baby Yoda were talking about it earlier. And Baby Yoda was saying, I don't know what's going on. Skelly says, well, I'm worried if it's either too short or too long. So your PR interval, this is interesting, is the PR interval, you don't want it too long because that means you're getting into blocks if it's too long. But if it's too short, you also have issues with WPW. So we want it in between what? Let's see. Do we have questions here? Yes, Marcia said if it's wider, the impulse is slower coming from the ventricle. Perfect. Yay, KJ, you're so good. Yes, so KJ says is C on this one, 120 to 200 milliseconds. So we've got a couple of people already typing that in. Yay. Y'all are like super fast typers. I am terrible at typing, especially when I have my keyboard up here. So I'm always a little bit slower. How are we doing? Are y'all doing okay so far on this? We're already a third of the way through getting to be a millionaire. So here's a little bonus question for 750 points if you're adding up your points to see how you're doing. What do you think about this? We hadn't actually talked a lot about blocks, but this is a type of block. And sometimes on the 12 lead, it's really hard to see blocks in the 12 lead. So you want to look at the rhythm, you want to look at the rhythm that's brought out down here at the bottom. So if you look down here at the bottom, it's lead 2, and you can kind of look across there and see what kind of block that we've got. So yes, Marcy, it is a block. So I want you to think about this. And this is how I think about blocks. I know a couple of people have already typed it in, but if I look at that rhythm, strip, and I say there is some missing QRSs, there is some missing R waves in there. If there's missing R waves, you are in a type 2 block. You are in a type 2 block. So now you have to realize, is it type 1 or type 2? In that, I'm sorry, Mobit's type 2. So you're in a second degree. You just have to know, are you type 1 or type 2? Let me make sure I said that correctly. If there's missing QRSs, if there's dropped or missing QRSs, you are in a second degree heart block. You are in a second degree heart block if there's missing ones. If the PR interval is always the same, it's type 2. If the PR interval is different, it's getting longer drop, then you have a winky block. So on this particular one, it is a type 2. That's because I see a missing QRS. Hopefully you can see my little pointer there. I see another missing QRS. So now I just have to say, is the PR is always the same? PR always the same? PR always the same? PR always the same? PR always the same? I have a second degree type 2. Okay, I want to make sure I was clear on that one. That's a bonus that was a little bit harder, but I wanted to kind of push that in. Now, Jennifer talked about 3 questions that we always ask ourselves. The first thing we ask ourselves when these patients come in with a rhythm, what do you have to worry about? And KJ's always already typing in. Also, I've got a couple people that are already typing in, and this is for 1,000 points. Let me see where. There we are. Yeah, I've got everybody on Facebook. I'm just making sure that I can see your chat here. Okay, so what are the three questions that we always have to think about? We look at that rhythm and we immediately say, is it fast or slow? Get my little, come on. Ah, nope, didn't show. There we go. There we go. Is it fast or slow? Is it wide or narrow? And is it regular or irregular? So on this particular one, the patient's very irregular. They're narrow. So something's going on with that one. This one's a little bit, let's see, 300, 150, 100. It's between right around 100, maybe 75 to 100. So they're not super tachycardic. So, but they are an irregular rhythm on this particular one. But the things I want you to think about when you first look at that rhythm, you say, is it too fast? Is it too slow? Is it wide? Are the QRS is wide or narrow? And is the rhythm regular or irregular? So that's the big things to answer on those questions. Now, yes, Matt's got it. A, C, and D. Perfect. Thank you. Thank you. Okay, so super questions. Any questions so far in there? Any questions so far? Does it seem like it seems to be making a lot of sense? And again, this is just kind of a review of the stuff that Jennifer had said. Now, she didn't talk a lot about AVR yesterday, or Monday and Tuesday. Today's Wednesday. But the research on AVR has been so much research in the last couple of years. And I've always used AVR, particularly because if the electricity in AVR, because the electrode in AVR, and I'm going to grab my little electrode, because when I teach EKGs, I use great big, huge electrodes for my person. And I use a thought process that this electrode that's up here on the right shoulder, AVR up here on the right shoulder, my electrode's going to be up here on the right shoulder. And I use a concept of a camera. My camera is the electrode. This electrode that's going to be up here on the person is up here is my camera that's looking at the heart itself. So now if I look at my heart, here is my heart on a stick. We call it heart on a stick. If my camera's up here on the right shoulder, looking down at my right side of the heart, that right outflow track, the electricity is going away from the camera. The electricity is going away from the camera. If that's the case, in AVR, the electricity should always be negative. The electricity should always be negative. So my P wave is negative, inverted. My QRS is negative or inverted, and my T wave is negative or inverted. So because of that, if it's not inverted and it's upright, if your QRS is upright in AVR, it's probably a ventricular arrhythmia. So that's why when you look at this answer, and this is kind of, I wanted to just give this answer, the explanation to this answer. So the answer is arrhythmia recognition, because you get to see the difference between ventricular tachycardias and SVT. Ventricular tachycardias and SVT, because in AVR, the electricity is going away from, in AVR, the electricity is going away from that camera. If I have that camera up here on the right shoulder, the electricity, this is electricity. I always use a big green arrow to indicate electricity. Electricity is going away from the camera, so the electricity on paper is negative. But if the electricity were to start at the bottom of the heart or the ventricle, as it would in a ventricular tachycardia, the electricity would be going backwards up toward the camera, and it would make an upright R wave. So that's one of the ways we can look at AVR. The other thing is AVR. Yes. So Marcia was asking, thanks for the explanation. The example is showing a positive or an SVT. Yes, that is perfect. So if it's a supraventricular tachycardia, the electricity is still going the normal way. So this would be SVT, normal electricity, VTAC, not normal electricity. SVT, normal electricity, VTAC, not normal. So upright QRSs in AVR. I know it was a long explanation, but I love AVR. So also the research has talked about the recognition of left main occlusions when you have any type of darn, it's not coming out, STEMI accusations in AVR, or that ST elevation in AVR. It's very sensitive to left main occlusion. So that was a lot of explanation for only 2,000 points. Sorry about that. Okay, so our QTC. Now, Jennifer talked about the QTC last night, and the QTC is very important. What should it be and why? Give me a hint. Okay, so y'all already have the answers. It should be under about 460. That's our norm. Yeah, we really like to have it a lot lower, because what happens? What happens when that QTC gets long? And it's all the drugs that I like Zofran. It's my favorite drug. But yes, you're going to have some torsades issues when that QT gets too long. That's one of the complications that those patients can have. And I always love that part of the body, because I'm a ventricular assist device nurse. And so the diastolic part of the heart is right there where that QTC is happening. When that T wave gets too long, diastole gets occluded. And my brain just goes crazy when we start talking about diastole. So off on a tangent. Sorry about that. All right. So back to Jennifer's thought process of 3 questions. Am I fast? Am I fast or slow? Am I regular, irregular? And what is the other one? Am I narrow or wide? What would you think about this particular rhythm if that were the case? And yes, y'all are already typing it in. It is fast, regular, and narrow. Paul says vitamin Z. Yes, I know. I love me some Zofran. I love me some Zofran. Okay, I have to be careful now, because we're always talking about how you have to watch all this stuff. And that's probably the only drug that I would take if I liked it a lot. Okay. All right. So what is your impression on this one? We look at, is the patient sick, big sick, or little sick? Big sick or little sick? A hint on this one, look at AVR. Look at AVR. If you're worried about this patient having a type of tachycardia, and are they sick or little sick or big sick? And Matt is saying B, big sick. And Michaela is saying big sick. KJ is yes. So this patient is big sick ventricular tachycardia. So I'm going to get my little arrow out here. Where's my arrow? There, my little laser pointer. And I'm just, oops, go back. My little laser pointer here. I think I got it there. Okay, so look up here in AVR, just a quick little thought process. Are we tachycardic? Yes. Are we ventricular tachycardia? It's wide. So we would look up here, just take a quick look at AVR. And if these R waves are upright, then that means that electricity in AVR is coming back up to my right shoulder. So we're probably having some ventricular tachycardia. See if that, yes, Matt says, check out AVR. I love AVR. It's just, she's like my best friend now. There's like 13 different things that AVR will tell you. When I go over them in our 12 lead class, I actually give you one little PowerPoint page that just talks about what AVR can do for you, but I go over it a little bit more in detail on these particular things. So she's like my best friend. Okay. All right. Let's see. Where are we? We are at 16,000 points and we're doing good on time. Perfect. Okay. So there's 2 leads. When we talked about those T waves, they should always be upright. T's are supposed to be upright because the electricity in the heart is going this way. So that repolarization is the T wave. Y'all are typing it in already. That T wave is repolarizing. So it should also be repolarizing in a positive manner. But two waveforms, excuse me, two leads, those waveforms, the T wave should be negative or inverted. And yes, y'all already had it, AVR and V1. AVR and V1 should be negative. So in the big picture. All right, so yay, we are almost halfway through to being a millionaire. Oh, actually a little bit more than halfway. We're at 64,000 points. Oh no, what do you think about this one? This one's a little scary. Am I big sick? Am I a little sick? What do I do? He started off little sick, but then he turned into what? What? Yeah, Matt said join the AVR club. Matt joined. Man, we should have that on our t-shirts. We should put AVR fan club on our t-shirts. That would be so much fun. Maybe Skelly should get a new t-shirt. I can embroider him a new t-shirt that has AVR on there. So what do you think about this? Yes, y'all are already typing it in. It is C, big sick. We need to defibrillate this patient. So they went into a tachycardia. Free the T's. I know I'm still working on that one, KJ. That one taking me a little bit longer to get the program that one in, but I'm working on it. Okay, so I did pull out another one on this just so you could kind of see it a little bit clearer on this patient. This patient was in a tachycardia and they defibrillated him, and then he went into a sinus rhythm. I just kind of like that. It looks cool. Okay, what do you think about this? When we say the word big sick, little sick, I don't know if I had heard it described like that before I started working with Jennifer. We just said, oh crap, probably because I worked in the CVICU. So we would just say when somebody was having an issue, we'd say, oh man, crap. So, but we like to use the term big sick versus little sick. Big sick means, what do you think that means? Yes, and somebody's already typing it in. Yes, so you're actually stopping everything and you treat the patient. Big sick, stop and treat the patient. Versus little sick, oh, I can look around, I can look at their T waves, I know something's going on, but I really got to spend some time thinking about it. Is it pericarditis? Are they having a STEMI? Are they repolarizing? Are they having wellings? What are all the things that are having with the patient? So I wanted to bring that information out because sometimes we use words and then we don't really explain them. So I like to make sure that I've explained them. Okay, so I don't think Jennifer's on yet. I'm waiting. So if she's not on yet, we're going to do this. So Jennifer talks about the 10-step approach to looking at 12 leads. And again, we go over this a lot slower, not in a fast game-like thought process, but a little bit slower when we're in our 30-day classes. But as you can kind of tell, I need a lot of visuals to remember things or to make them make sense in my head. So I took her 12 lead, I took her 10-step system and made it into a clock. And you can take a screenshot of this if you want to, because I just made this up. So it's not copyrighted or anything. So we look at the patient and we've got the big sick, little sick down, but what are all the things that we need to look for in that 12 leads? So what I did is I took her 10-step system and I made it into a clock and I put the normals on the clock. So as I go through this super quick, I actually wrote the normals or I typed them out there for you. So is the patient sick? A little sick? Big sick. So that's the first thing. So how fast is the heart rate? Normal is 60 to 100. I put that on your list there. Is it regular, irregular? Okay. And then the next step is I'm going to look at those intervals. And I've put the normal intervals there for you. The PR is 120 to 200. I remember it's someplace between 3 and 5 blocks. 3 blocks and 5 blocks. That's my PR interval. The QRS needs to be under 3 blocks. PR interval, 3 to 5 blocks. QRS, get it under 3 blocks. And then the QTC under 460. So, and y'all already had that down pretty good. So tell me if you've got any questions. Hopefully I'm not going too fast. The axis means that the electricity, and again, I'm big for the little arrows, the electricity in the heart normally goes this way. It starts up at that sinus node, goes to the AV node. Can you see my little sinus node, AV nodes on here? Starts at the sinus node, goes to the AV node, goes down to the bundle of His, goes down to those ventricles. So it's kind of going this way in the body. So if you're to look at, if you looked at an axis wheel, and this is way not what you need to know, but the normal axis is 0 to 90. What that means is the normal heart electricity is going this way in the heart. Okay, so that's the normal activity in the heart. So the next thing we're going to look at is there ST elevation? If the patient's super sick, we'd be looking at that ST elevation right away because they popped back up there to the big sick. I need to find out a way to make that little clock pop itself back up there to the big sick. But we're going to look to see if patients have, this is key, do they have ST elevation in 2 leads that are contiguous? And we like to say those contiguous leads, so it's that area of the heart that those coronaries are that my camera would be in. If my camera is down here looking at the inferior leads, I have leads 2, 3, and AVF. 2, 3, and AVF are looking at that. If 2 of those leads say, hey, I got some ST elevation, I'm over here looking at leads 2, 3, and AVF. What do you say, 2, 3, and AVF? Are you having some ST elevation? Yes, I'm having some ST elevation, and it's just terrible. Then you would look in the opposite wall of the heart, up here in this lateral wall, and you'd be like, lateral wall, are you depressed? The lateral wall says, yes, I'm very depressed, and I'm going to call that reciprocal changes. So we say if one wall of the heart is having a heart attack, you're going to see ST elevation. So 2 of those leads are going to be up, ST elevation. The opposite wall should show the opposite effect, or ST depression. So if my lateral wall is saying, I'm having a heart attack, my inferior wall would be saying, I know, it's very sad, and I will be depressed for you, and I will be depressed for 24 hours, and we're going to call that reciprocal changes. So we like to say they're 2 up, 2 leads need to have ST elevation, and 2 leads need to have ST depression. So that's the 2 up and the 2 down. So that's what that means. Okay, and we're still doing good on time-wise. Jennifer should be here in just a couple minutes, so we just got a couple more little questions, or a couple more things here to go. All right, so hypertrophy is, are the R waves really big, or the R waves really little as you go across that 12 lead? So you're going to be looking at that because there could be all kinds of things that's happening to that heart. Or you may just have somebody that's got a big chest or big breasted females that sometimes you're not going to see that R wave, but you're going to look at those R waves and see, is there issues with those? Then number 8, and I'm going slow on this because I just wanted to explain my clock system around there and just take a little time since we've got some time. Now we're going to look at the T waves. We've already talked about 2 of the 2 of the leads. We talked about 2 of the leads that the T waves need to be inverted. We talked about that. That's AVR and V1. That's because the camera's up here on the right shoulder. AVR and V1, the camera's up here on the right shoulder. It's more of a right-sided EKG. So those leads, the T waves should be inverted. Yes, think about them saying they are depressed and will be for the next 24 hours. Yes. So let me just see what she was asking. Does the voltage change when limb leads are applied to the torso? I have to think about that one. I have to think about that, Marcia, when they're applied to the torso. I'm having to think about your question physically and to see if the voltage changes. When it goes across the R wave, Marcia asked if the, question went away. Does the voltage change when the limb leads are applied to the torso? Oh, I see what you're saying. Versus if they're way out here on the arms, is that what you're meaning? If they're way down here on the arms versus if they're closer to the body, is that what you're asking? As far as I know, it's not. But I may have to do a little research on that before I say for sure, just to make sure that I am saying that correctly on the voltage. Okay. And definitely no question is ever crazy, because if it is, I would have already asked it, because I've asked some crazy questions, let me tell you. So we've talked about T-wave analysis and sorry, my little clock didn't want to go there. Okay, there we go. Now, once we've talked about the T waves, then we also look for Q waves. You should only not really have any Q waves. And I think Jennifer's already talked about this. Paul said no changes in voltage in my experience. But I'm just gonna look it up. I've got a couple of people saying no, but let me just look it up and research it and just make sure that I'm saying that correctly. And definitely depends on the size of the patient for sure. Q waves, is there Q waves? If there is Q waves, they need to be very small and not wide, small and wide. If they are very deep or very wide, deep or wide, or if they are in a pattern, and we've got a little pattern here. See my little highlighter here? This HOCM, and this is a little bit more advanced, but I'm going to throw it in here. HOCM is hypertrophic obstructive cardiomyopathy. When you have a patient that has in the wall here on the inside wall of the heart, when that wall gets thick wall here in the septum, they get hypertrophic cardiomyopathy. You will start to see on the EKG deep daggery Q waves in the lateral wall. So you're going to see it in my lateral wall, which is the wall up here on this side. So I'm going to see it in AVL and V1, AVL and V1, and V5 and V6, which are right here on the side of the heart. So that was a little bit more advanced, but I wanted to kind of throw that in because I like to throw some stuff in there to make you challenged a little bit. Okay. And then we're going to pull it all together. So that's why she calls, Jennifer calls it a 10-step system. Take all that information, but you're going to look at it systematically. So when we go through the 12 leads, we actually take this and go through it in those leads and look at it and say, what's going on with the patient? And then there's a couple of things that you're going to see in some odd leads, especially the V leads that are very specific. We can see brugadas, we can see wellings, we can see a posterior wall MI. So there's some things out there that we talk about in the class on the V leads that are very specific for that. And that's in V. Usually V1, V2, and V3 are kind of the specialty ones in that. So we kind of put it all together and say, how is your patient and what are you going to do? So that's our thought process in that. Okay. Oh, there's Jennifer.
Hi.
I think we did it right on time, girl.
Yeah, you're amazing. That's all I can say. So guys, how much did you love Michelle's session? Like, was it amazing? Oh, I see Tammy. Hi, Tammy. Hey, Anna, you got people to put their cameras on?
Yes,
You're
we had lots of
amazing.
cameras. We had lots of cameras. I love being able to see where people are. I've got somebody that's got a clinic behind them. I think that's super cute.
I know.
Francine's got a clinic behind her.
Well, let's get kicking off with the second session so we can round up our night. But we have a lot of exciting news tonight. Not only did you get to hang with Michelle and do a game and then like the 10-step system, that right there would have been enough. But we're going to rock your world now with a little bit more 12-week basics. But just to, as promised, we have a couple announcements. Okay, so first of all, announcement number one. Now, Michelle, I got to know, were they being helpful to each other tonight in the chat? Were they cheering
Oh
each
my
other on?
gosh. Oh yes, for sure, for sure.
Okay. All right, because that's what we were looking for, as you guys remember, in honor of my dad. And so we actually selected a winner, and that winner is going to win a 1-month pass into our 30-day EKG challenge. So are you on tonight? And if you are, where are you so we can congratulate you? Is she on?
I think so. I thought she
I
was
thought
in
I
the
saw her.
Zoom. Yes.
Yeah. Oh, okay. Marsha's saying congrats. Yeah, yeah, yeah. So anyway, reach out to me so I can get you access to our 30-day EKG challenge. Congratulations. You were picked because you were exactly what we were looking for. You were supportive. You were cheering on your other fellow classmates, and we love that. So we wanted you in our environment because that's how we are in our 30-day EKG challenge. Now we're going to start on the 15th, which is Monday. And we will be kicking off with EKG terminology enhanced. And then we will have a bunch of classes that week, getting you super confident and comfortable. And if you liked Michelle's lecture, you're going to get to see like an expanded version with all the things. Okay. On the first week, we're going to get you like super comfortable. So you'll have this week, next week, and then you'll be in for 30 days with us. So yay, you won. Yes, that's you, right? So congratulations. Message me on Facebook Messenger so I can give you your links. and everything that you need to join us as our guest for 30 days. Okay. Anyway, moving on, there was some other winners really quick. We had Marcia. I saw Marcia's on here. Marcia, you won one of these badges. Remember last night, we did some random selection, and Marcia, you were one of the winners. So was Lisa Harrison. So hopefully, Lisa, you're on. And of course, we also had Jean Smith. So if you are any of these workbook or sorry, badge winners, let me know and I'll pop them in the mail for you. And you're gonna love them. They are so cool. This is by Scope Education, Matt Holden. We absolutely love having him as one of our coaches. Okay, so let's get on to, oh, that was last time. Okay, let's get on to our knowledge for tonight. So let's quickly, and I know Michelle probably already glanced about on this already, but you have to understand that the EKG software interpretation is really not that accurate. So you can't rely on it. That used to be my plan. Oh, I'm going to use the software interpretation. And then after that, I'm good because the computer is smarter than I am, but it's wrong a lot of the times. So what does that mean for us? It means as providers, we actually have to be the last word on the EKG. We actually have to know what we're dealing with. So going back to some fundamentals, hey, Matt just gave a great class in our EKG Launchpad, which by the way, I think it's Michaela, is that how we say your name, our scholarship winner? You're also going to get access to that for 30 days, our EKG Launchpad group. And so you get access to 2 groups. We do basic classes in our Launchpad, and you'll get access to that for 30 days as well. Matt Buchanan just did a great lecture tonight, and Michelle chimed in as well. So it's been a night of learning, let me tell you. But anyway, we'll get you all hooked up. Now, if you didn't win, we're going to talk about more at the end, how you can join us, because it's an amazing opportunity to get some more education on things like this. So going back to the 12 lead, you have to have the T waves all be upright, except for V1 and what other one? AVR, right? All T waves except for AVR and V1. Those should be inverted. If anybody else is inverted, there's a problem. Could be ischemia, could be a PE, could be all sorts of different things. And then also you want to look at the intervals to make sure they're normal. You want to make sure the voltage isn't too big or too small, and that the family is all following the rules, right? The P wave is the baby, the QRS is the dad, the P wave is the mom, the QRS is the dad, and the T wave is the baby. And that's important when you start talking about things like heart blocks. And so looking at the normal EKG, I just wanted to throw this in here as a little bit different way to look at this. So I'm going to get my pen out and draw on here. This is right here. This is your 12 leads, okay? And what this is a rhythm strip or your long lead, either way. That's what it's called. And so this is the one you're going to use to decide what the rhythm is. Now, what you'll look for is a P wave, right? We talked about that last night. Look for a P, making sure every QRS has a P, making sure the R to R is normal, and it is. And going on up here to the rate, it's 42. So the machine is actually right. It is a sinus Brady. But also knowing that here's the mom, here's the dad, here's the baby, the family. And another really important point to know is that we must, on all of our leads, we must draw a line along our isoelectric line to see if there's any ST elevation or depression. And so we're going to do that every time, every EKG. And there really isn't any to speak of. We're going to look right here at that ST segment, and there really isn't any. How do you find the isoelectric line? Well, honestly, that's pretty easy. All you have to do is go to your end of your T to the beginning of your P. That is always going to be your flattest line, or isoelectric is the term for it. Okay, so is there any questions on this so far? Let me see. Draw your lines. Yes, KJ. Okay, good. All right, now this is an example of another EKG, just to quickly show you. I drew a line. You would do this on every one. And then looking at the T waves, right? AVR and V1 are inverted. And then making sure all the T waves are upright where they should be, and they are. And another quick little tip is knowing that these numbers here are important. So your ventricular rate, we go over this way more in our 30-day EKG workshop. We actually give you this 12 lead and we have you color code it and go through the intervals. But basically knowing that there's a couple clues that can come through these numbers. And one of them is a short PR interval. If it's under 120, it's a short PR interval. And that can indicate a Wolff Parkinson's white. That would be something you wouldn't want to miss. And then a prolonged QT, so a QTC over 460, you have to worry about more of an incidence of torsades. And then a lot of people have some real struggle with axis, which is here. Axis should be 0 to 90. And so it is normal, which is good. We'll talk more about axis in the 30-day if you want to know more about that. But knowing that this EKG is a good example of what is normal. Okay. Now, 10-step system, we had Michelle cover that at length. This is a little bit modified version, but essentially the same thing. And so you can use that and practice that as you go. But basically, this EKG, let's take a look at this real quick. What is happening here? And what should we ask the patient? Would you think this is a big sick or a little sick? Big sick or little sick? What do you guys think? Okay. Yeah, so if you think there's no P's, so what you'll do is, well, actually, I see why you think that, because the P should be right here, but it's not. It looks like this could be a P. It looks like there's the same ditzel here, same ditzel here. And if that was true, that would make this a sinus Brady, right? But there's a very long PR interval, right? It's over 200. And so, yeah, this is a profound first degree block. This is a really long, this is, I think, my longest first degree block I've ever seen. So the question we would ask the patient would be, how do you feel, right? And if they're symptomatic with a rate of 44, then that's something we're going to address, right? We always want to ask. This guy could be a professional athlete and his normal heart rate is 44, but essentially just wanted to have you pick up the eye of the PR interval. Do you exercise a lot? Exactly. It's a great question, KJ. So another thing to go over, and I think probably Michelle went over it a little bit, is that STEMI, you must have 2 leads of elevation that are contiguous, and you must have 2 leads of depression that are reciprocal, which are the opposite. Michelle, did you talk about that already? Contiguous, reciprocal?
I did. And I even did a little heart voice.
You got to hear Michelle's heart voice? Oh my gosh. Okay, amazing. So that's what we're looking for with STEMI, because if you don't have reciprocal changes and you just have elevation, you don't have a STEMI. You have something else. You most likely have pericarditis. But you must follow these rules each and every time. Okay, here is a chart. And she showed heart on a stick. Oh my gosh, you guys got all the things tonight. So this is basically the arterial supply. This is the changes that you will see. This is the names or location of the infarct. And this is the graph of reciprocal changes. I'm going to tell you, I don't like this. This is how they gave it to me. I do not like this visual representation because it doesn't help me understand. So we actually created a visual for this that we help you with in our 30-day if this doesn't work for you either. But this is the list should you need it and should you want to refer to it. But you must have reciprocal changes to have a STEMI. I'm going to show you what that looks like. This is not a real patient's face, but it is a real patient. And he says, the bad thing that I hate the most, it feels like my last MI. Okay, I'm interested. It happened after he lifted a heavy box, so it's exertional. It radiates to his jaw and his back, and he has a history of stents, and he's got hyperlipidemia and diabetes, so he's kind of high risk. So what are your differentials, Remy, little baby Remy? So basically, the differentials were really, really concerned about ACS, right? Yeah, little baby Remy. So Remy's also concerned and he does need an EKG. I totally agree, Marcia. So here's his EKG. Let's see. Okay, so our 10-step system goes out the window when we have a STEMI accusation because we go straight to step 6, which is look at your ST segments. So what you're going to do is you have an accusation by the machine that there's elevation. So you're going to go find it. draw your lines, as KJ always says. And KJ has correctly identified that this is indeed an inferior MI because you have elevation in 3 and F that is more than a box, more than one small box, and you have the reciprocal changes of depression. Now, actually, for that per that chart, 1 AVL and V2, those are the reciprocal leads. Okay, so we actually had elevation in 3 and 3, but you just need 2 and 2. Okay, so we are thinking that the right coronary artery is involved, and sometimes with that you can have rate issues or bradycardia. Now let's talk about this EKG. I teased about this on Instagram this morning, so I want to make sure I cover this. But this is a patient who says, I feel weak. I know how you guys feel about that chief complaint. Nobody likes I'm weak. And so what are we going to think about for him? Well, we're in an EKG class, so we're absolutely going to get an EKG. We're going to look at his blood pressure, his meds, get a CBC, CMP, TSH, all the things. But here we go. He has marked ST abnormality. Well, let's see what they're talking about. This ST, oh, okay. Well, when I draw my lines, I start to see something emerging. What's actually emerging here? What is starting to form? What do you guys think? Yeah, depression, absolutely. So if we understand that this is depression and it's in V2 and V3, the reciprocal changes would be on the back, the part of the heart we don't measure. So what do you think this is? And what do you think we need to do for this patient? What is this? And what do we do? It's a posterior MI, exactly. How do we know? Because, well, we could verify, we could get a V7, V8, V9, and we could verify that looking for elevation, but they do need to go to the cath lab. This is definitely a no-brainer. Send them to the cath lab. So if this is something that you're still kind of like struggling with the concept of, we actually show you in 3D in Michelle's class how to kind of think about this, but it's only going to be read as marked ST abnormality. And I got to tell you that literally, if anything keeps you up at night, it should be that when it says that, because there's at least 5 bad things that need to go to the ER when it says marked ST abnormality or non-specific ST wave changes. And we actually do a whole class on that, on how to stay safe and pick up those findings, because this is one of them, posterior MI. And now you know one of them. So hopefully you'll sleep a little bit better tonight. Hopefully. Okay, so now we're on to the workbook. And what I'm going to do is I'm going to let you go through this on your own, because the last 2 I haven't. But I'm going to let you go through these on your own so that I don't give away the answers. The answer key is in guide night 3 for you to review if you want to. This is a practice EKG, drawing your lines and seeing if there's elevation or depression. Oh, I'm not going to let you, see, I'm going to let you do it later. And I'm going to let you go back. This is a blank 10 steps should you want to practice writing that out. In your workbook, it's there. And we'll go through it really quick. And that's your practice, okay? And you also have this where you can label the conduction system and also practice writing in your intervals on this if you wanted to. So remember on night 1, we kind of went over this. Night 2, we did a little bit as well. So if you want the practice, and of course I have the answer sheets up there in the guide 3. And thank you so much for attending our 3-day EKG challenge. I'm so excited to meet you all and have had you with us. I do want to tell you guys, if you're interested in our 30-day, I'm going to tell you just a little bit about it if you didn't win the scholarship, so you know what the program entails. And if you want to join Michelle, me, David, Sean, and all the other great coaches and students in the program, I'm going to give you some details. So, and also, by the way, in the chat, if you have any questions, type them in. We'll be happy to answer them about anything we've gone over for the last 3 nights. But I wanted to share with you kind of what this program looks like and the meat and potatoes of it really quickly. A lot of you have been asking me, when is the next one? The next one starts Monday. We're going to do an EKG class on basically on steroids for EKG terminology. And we're going to show you around the group, okay? The next day, we're going to do rhythms with Sean. So you're going to get some immediate rhythm exposure where you get to practice. So we taught you the rhythms in last night, and then you're going to get to practice them on the 16th. And then on the 17th, Michelle is going to take you on a 1.5 hour journey through basic 12 leads, where she uses all the Skelly, the heart model, everything, heart on the steak, and she will get you to understand 12 leads. But we're going to round out the week with David, who is our EKG master, and he's going to go over a certain topic, whatever the group has chosen. Or if you want to send in an EKG, he'll go over it in his lecture, and you can attend live and ask questions. Or you can just say, David, hey, this is my question. And then on the 21st, so I'll be sending you this box full of stuff, full of a workbook, full of cheat sheets, full of crayons, full of everything that you're going to need for the workshop on the 21st. And that's where we're going to do the high risk EKG findings that are like really important. We're going to gloss over them, do some practice. We're going to spend about 2.5 hours together that day, and it'll be recorded if you can't make it. And then Michelle's going to do some more practice. So what she teaches you here, you're going to practice here, and that's a really good session. And then on the 28th, I'm going to come back and review more high risk findings with you. And then we're going to do a little bonus session on heart failure. And of course, we'll have more classes coming up in May. And when you join us, you'll get 6 months access. Our scholarship winners get a month. But if you join us in the program, you actually get to stay in for 6 months. You get access to all the live classes and 3 years of recorded classes. So basically, this is access to coaches, real people, to answer your questions. As you can see, we're very approachable and we love questions. And you get access to all the past classes. We've had several guests come in and do classes for us. We have a lipid specialist, NP, who's done a bunch of lipid stuff. We've had stress test, LVAD, how to read echo reports, new CHF guidelines, cardiac pharm, deep dive on anticoagulants, deep dive on antiarrhythmics, like you name it, we've got it. And you get 12 hours of CE. And the cool thing about this is that if you join now and you submit your 12 hours of CE, you're going to get, so you'll be in the program with us for 6 months. You're going to actually have a chance to get another 12 hours after May. So, because it'll be a different program by that time, like a slightly different, so we can apply for new CE. So you'll actually have a chance to get a total of 24, which is a really cool time to join. So that's cool. And so we're going to send you a badge that looks like this, or we'll send you a bigger one that's the window. We're going to send you the workbook. You're going to get access to both groups, the 30-day EKG challenge, where all those classes take place, but also the launch pad, where we have some bonus classes coming up in May that you'll get access to as well. And then you'll get a learning portal as well, where all the classes are housed for CE. So that's the really cool thing. Now, the prices to join for 6 months are very unrealistically low, considering that you get all the stuff in the box, the toys, access to coaches and live coaching. But for student rates, we make it super reasonable, $149, because you don't need CE. EMS, we really want to have you join us. We make the price very reasonable. And you do get your 12 hours of CE. RN is $249 and NP or PA is $299. And you just go to the website and you can pick which one you want to join at. If you're like, hey, you know, money's tight right now, but I really like your vibe, you guys, then join at the student rate and just don't get the CE. But you still get access to all the same things. Both groups, you get the presents and all the things. So here's kind of a wrap up. You get the hands-on workshop on the 21st that's live. You get access to the EKG Launchpad, where we have classes every Wednesday at 4 o'clock PST. You get a welcome kit mailed to you. You get 12 hours of CE, live weekly classes, sometimes multiple. We have guest speakers come in all the time, and we have something called study halls, where you can come get your questions answered by EKG masters. So anyway, this is a really great program, and I think the link is in here. Thank you, Ruben. And there is so much in the library. So now I want to take an opportunity to answer any questions you may have, since we're wrapping up our night. Is there any questions on anything we've covered? I'm going to just check Facebook real quick. No, thank you, Matt. Matt's also one of our guest coaches. And he and Sean have done some duets, which was really cool. Okay, so any other questions? Just the voltage limb question. Let me see where that question is. Michelle, do you see a voltage question?
She had asked, I need to look that up, if there's a difference in voltage if you have your electrodes, is why I'm understanding the question. If you have the electrodes placed on the torso or versus on the arm, does that make a difference in the voltage? So I
That would be
don't
it.
think it, but I need to make, I'm going to do some research. I told
Yeah,
her I would.
I don't think it does either, but I think yeah, it'd be a great question to come to study hall and ask David. He knows all the things. All right, you guys.
Yeah.
It's been so fun. Make sure that you, if you want a spot, that you grab your spot, because we're going to be starting Monday. And if you want a spot, I need to get your kit in the mail. So it goes out on time, so you have all your goodies by the time we do the workshop. Okay, you guys, it was so fun. Thanks to Michelle for kicking it off and doing a wonderful job as usual. Thanks to all of you for coming out and spending the last 3 nights with us. It has been so fun. And we appreciate you, and KJ as well, for just always being the cheerleader, and Matt, KJ and Matt, like they're in our 30 days. So if you love KJ and Matt, come on over. All right, guys, we'll see you soon in the 30-day. Next week starts on Monday, and have a great evening. Bye. Have a good night.